Mike, I think, is there and will talk to us now. Thank you, Mike.
Thank you very much indeed, Tony. And thank you, Carel, for a very clear discussion of the links between COVID-19 and obesity. I'm not going to say a great deal about COVID-19, except to reinforce the point that obesity clearly puts people at risk of more severe and more outcomes of the disease. And it's not just obesity, but it's obesity with the complications of high blood pressure, high glucose, type 2 diabetes, and existing heart disease. So that sort of triad, the metabolic syndrome, has really come into its own here, and not as being more likely to contract the infection, but as more likely to do badly and indeed to die from it. And this has raised right up the priority list the issues around weight management. I'm going to talk to you largely about the DIRECT trial, and I can spread my discussion further at the end. And this was the very first clinical trial ever conducted with the aim of taking people with type 2 diabetes and taking away their diabetes completely so they were no longer diabetic after substantial weight loss. Now we are clicking here and the thing is not moving on. Aha, oh dear. Clicked off. Ah, yes. The next slide here shows my sort of starting point, which you're all very familiar with. Without COVID-19, type 2 diabetes is in fact one of the most tragic and most serious, cruel diseases, which takes away people's lives, it destroys families, with all the major complications listed here that we're all very familiar with. Now, we were taught as students that type 2 diabetes was permanent, it was incurable, treated with tablets, and inevitably progressive. However, since when I was a student, the average age of onset was around 70 years. Most of our patients with type 2 diabetes did not suffer the complications seen on this list. And the big difference that has happened in the last 30 years, 40 years, is that with the obesity epidemic, people are now developing type 2 diabetes, not in their 70s, not even in their 60s, but commonly in their 50s and even 40s and younger. And these people are mostly now developing the complications, and these are very serious, and the complications are untreatable, they're permanent. Just to put this in some perspective, the life expectancy of people with type 2 diabetes is reduced because of these complications, and it is reduced by about 6 or 7 years, even if we give all the best treatments that we have available, the best medications, using guidelines, and these are data from across Europe. They're very similar in individual countries. About 6 or 7 years of life is lost on average by people just because they have diabetes, men and women. And there are a lot of different treatments which we are familiar with. Huge numbers of drugs have been developed to reduce blood glucose, to reduce hemoglobin A1C. They do not improve the life expectancy. That reduction in life expectancy remains more or less the same as it was 30 or 40 years ago. And I'll just put this in perspective again. If you or a member of your family were to develop a disease and you were told it had a 10-year survival of 80%, would you be worried? Well, you might be worried. If it was 60%, you most certainly would be worried. If you were told it was only 50% 10-year survival, you'd be thinking this is a really rather worrying, serious disease. We must take it very seriously. Now, what are these diseases? The first one, 80%, breast cancer. Most people would regard breast cancer as a pretty serious diagnosis, something you take seriously. The second one, non-Hodgkin's lymphoma. These data come from Cancer Research UK. 60% survival at 10 years is a very poor survival despite our treatments. And of course, what I'm going to say and tell you is that from studies, particularly in Scandinavia, the 10-year survival with type 2 diabetes, 50% across the board. Now, that always are adjusted for age and such like, but it puts in perspective, type 2 diabetes is at least as serious as many cancers and more serious than some of the big cancers that we're frightened of. We should take it much more seriously. And we know the cause, we know the primary cause of type 2 diabetes. Of course, you have to have a genetic predisposition, but the primary cause is weight gain. And this extraordinary study from the Nurses' Health Study in North America, showing relative risks going up to 100-fold with a body mass index of 35. Important to recognize here that the risk of type 2 diabetes is already increased, and this is in largely Caucasian populations, roughly 10-fold with a body mass index of 25. So much of our type 2 diabetes is being seen with people whose body mass index is not obese and not even overweight by current terminology. And we also know from a number of major trials that quite modest weight loss of the order of between 4 and 8 kilograms can prevent the development of nearly all type 2 diabetes if it's sustained weight loss of that order in the diabetes prevention trial. So weight gain is the cause of this disease, and we know that preventing weight gain will stop it developing. The big question, can weight loss take it away? Now, the surgeons have said for many years that they see diabetes disappear when patients have bariatric surgery. The first randomized trial, which was done by John Dixon in Melbourne in Australia, showed this very clearly. It's a very small trial, but what it showed was in the black, the people who failed to lose much weight, their weight losses were under 10% in the main, remained diabetic after 2 years. And they're in the black in this slide with the usual diet, usual diabetic clinic, or gastric banding. Those who lost weight became white. They became no longer diabetic after 2 years. And they had a remission rate, no longer diabetic, not requiring treatment, of about 73% for bariatric surgery. I put a line on this at about 15 kilograms because that seemed to separate the greater successes from the lesser successes. And with that, you get 83% remissions with a 15 kilogram weight loss. People who lost more than 15 kilograms, 83% no longer diabetic after 2 years. And in fact, we could probably have put that line at 10 kilograms weight loss and got the same result. So this tells us that you don't need to lose 20, 30, 40 kilograms to get rid of type 2 diabetes. And 15% becomes the sort of target which is just about possible now with dietary approaches, perhaps also with more modern medications as well. And we know also from a very old study published, in fact, from Scotland in 1990, that people who lose weight with type 2 diabetes, if they're overweight to start with, BMI over 25, they will live longer. And this is a striking study because what it showed was that with 15 kilograms weight loss, the life expectancy of people with type 2 diabetes was the same as people who never had diabetes. If they failed to lose weight, then their diabetes would take 7 years off their lives. If they lost 15 kilograms, they would live as long as people who'd never had diabetes. So that 15 kilograms seemed to ring a bell. Based on these figures, we established the diabetes remission clinical trial, the first ever to attempt remission of type 2 diabetes as its primary outcome. We conducted this across Scotland and the northeast of England in collaboration with Roy Taylor, who works in Newcastle. We divided practices into controls who had all our guidelines. They got all the best treatment for diabetes. They didn't have to pay for it under the National Health Service, so all the top treatment, current treatment, which is recommended. The intervention group had the same guidelines, the same treatments, plus the Counterweight Plus weight management program, which I'll describe for you. And we had a very high uptake, people very keen to get remissions of their diabetes. And we selected people who were very typical of the sorts of patients seen in primary care. And these are patients who they don't go to hospital as part of the trial. They're seen entirely in primary care. Age 54, on average, body mass index about 35, hemoglobin A1C 59. And we purposely took people within 6 years of diagnosis. So they had diabetes up to 6 years. And they were not yet on insulin because this was conducted in primary care where the doctors were not so confident about adjusting insulin. The intervention, that, as I say, they were seen entirely within their villages or their practices in the country. They were seen on day one. And on day one, we said, we want you to stop all your anti-diabetes medication and all your antihypertensive and diuretic medications. And we had a protocol through the trial so that if blood glucose rose or blood pressure rose, they would restart medications. But our hope was that they would lose weight and that they would not many would require to go back on medication. They then went on to total diet replacement, which, as Tony explained, meant that they were being asked to take a formula diet 3 times a day, which would provide all their nutrients entirely safely, all the required nutrients, but only 830 calories a day. And on that, we expected them to lose somewhere between 1.5 to 2 kilograms every week if they followed it completely. Of course, many would not do that. But that was the wish. They were then seen 2 weekly during that time. They moved on to a food reintroduction program very carefully designed program to reintroduce foods, not the old foods they were eating before while they were overweight and diabetic, but a new normality of a dietary program, which would then lead them on to weight loss maintenance, and they were followed up to support them through weight loss maintenance for 2 years. Observations are continuing for 5 years, but that was the randomized trial. We're not moving on. Can we move on? Thank you. The results, which are shown here, I'll just explain the slide. This shows the phases of the intervention. So on the left-hand side of the slide, we see there was a average 14 kilogram weight loss during the total diet replacement phase of the trial. That was in the red, and that was mostly from patients who remained on the trial, and it's shown in the red line. Those who fell out, who dropped out, a small number, lost less weight during that period. These people went on to food reintroduction, where they gained about 1 kilogram, and that gain was mainly in those who dropped out of the program at that phase. Those who stayed in the program, in the red, their weight losses were maintained. Then into weight loss maintenance. Over the first year, there was a regain about 1.9 kilograms, and over the second year, about 2.8 kilograms. So there is weight regain during the trial. We were unable to prevent it completely, but these regains are rather less than had been seen with the old very low calorie diets, for example, where there wasn't a big effort to maintain the weight losses. Next slide, please. Moving on here. The primary outcome, as I say, was remission of diabetes. And when we set out to do this study, the target was that we should achieve 22% remission rate at 1 year. And I put a line here at 22%. We then assumed that our control group might have a 5% remission rate, just from previous evidence. Why 22%? That was because this is the figure where our public health doctors said we must take this very seriously and we should be putting this into practice if we can achieve 22% remissions at 1 year. It was also a figure which is twice as high as the remission rate seen in the Look-Ahead trial in North America. And we felt that we could do better than that in a British or Scottish trial. The next slide shows what we actually achieved. And as you may well have heard, that in the control group, the remission rates were approximately the 4 or 5% that we anticipated. In the intervention group, the remission rate was in fact 46% at 1 year, and that was still 36% at 2 years. So well over a third of our patients free from diabetes, not requiring medication, hemoglobin A1C below 48 millimoles per mole, so not diabetic under current criteria at 2 years. And if you look at this according to the weight losses achieved, the focus really is on the columns for weight losses of 10 to 15 kilograms and above 15 kilograms. And you can see that above 15 kilograms, the remission rate was 86% at 1 year, 82% at 2 years. So at least as good as bariatric surgery if you can lose 15 kilograms. And indeed, the weight losses for 10 to 15 kilograms, about 3/4 of our patients were no longer diabetic after 2 years. So it then emphasizes the need for the weight loss and maintaining that weight loss. We also saw a lower hemoglobin A1C with fewer patients requiring medication on this slide. And on the next slide, a lower blood pressure with fewer patients requiring antihypertensive drugs at 2 years. And these add up to an economic advantage. Thank you, the next slide shows that stopping the antihypertensive medications and diuretic drugs on day 1 was done to avoid postural hypotension, which is commonly a problem with rapid weight loss. There was no postural hypotension. And what we saw was that weight losses fell significantly in all groups, whether or not they had previously been on antihypertensive medication. So that at 2 years, 1 year in this slide, you can see that their blood pressures were approximately 1 millimeters of mercury lower for each kilogram of weight loss. They were on average about 10 millimeters of mercury lower than at baseline, even those who had previously been on medication. Some patients did require to go back onto medication, of course, about 30% at the end of total diet replacement. The cardiovascular risks fell significantly. In fact, they were halved in the patients who achieved remission of diabetes at baseline. The Q risk was 16%. That's a high risk of cardiac events. At the end of 1 year, the next slide shows that they had fallen to 8.2%, which is a lower risk, much lower risk, and their hemoglobin A1C was then in the normal range of 40 millimoles per mole. Next slide shows that there were fewer serious adverse events in the intervention group. That's a little bit unusual. Most clinical trials of drugs will have serious adverse events in the intervention arm. We found more adverse events in the control arm. The intervention arm had less, and they were largely diabetes-related complications, vascular complications of diabetes. And quality of life improved, which was an advantage. There was, the next slide shows that a very complicated analysis of the economics of this, which relates to the UK system, but also elsewhere. And I can tell you briefly that in the green at the top, our intervention group did have an initial cost of the intervention, but because there was a saving, they had less cardiovascular events, they had less drug requirements, their total lifetime costs were lower than the blue group at the bottom, the control group. So there was actually a saving of medication with improved quality of life and less diabetes. And the next slide just tells us that this trial has told us a great deal, which confirms and extends what Carel le Roux was speaking about in the first talk, that obesity is a disease where there's excess body fat. Initially, that is in adipose tissue, which you can feel under the skin, most of it. At a certain point, people start to export that fat into vital organs, into the liver, into the muscle, into the pancreas, and those organs fail to function normally when they become fatty. And that personal fat threshold varies between individuals. It is much lower for people of Asian origin and from people in the Middle East, so that the liver becomes fatty, and that's a signal that diabetes, if it hasn't already developed, will very likely develop in that individual. And we know now that this process of fat accumulation and export into vital organs is reversible, because in the direct trial, we also measured magnetic resonance spectroscopy to look at the amount of fat in these vital organs, and showed that with the weight loss, and those who had remissions, the fat was lost from the liver and from the pancreas, and these organs then started to function normally. The first phase insulin response regained. I won't read through the slide in detail, but I'll just say that across the world, particularly in the UK where we've done this study, but now in many other countries, populations are demanding a remission from their type 2 diabetes. Diabetes organizations are having to work with healthcare provision to actually provide services, and we are involved in a number of other clinical trials across the world, including discussions which you're going to hear about from Qatar later. I will mention very briefly, since it was brought up, that there are new regulations which are proposed and may well come into force in the next 2 years to reduce the magnesium content in the total diet replacements. And the theory here is that it would reduce diarrhea. This is extraordinary because we do not see diarrhea as a clinical problem with the current total diet replacements. It simply doesn't exist more than loose stools in the general population. And importantly, magnesium, of course, is a protective agent against type 2 diabetes. So to reduce the magnesium content would be a very mistaken move. There are suggestions that essential fatty acids should be increased to reduce heart disease. Well, we're already doing a pretty good job at reducing heart disease. And the problem with essential fatty acids is that they have a bad taste and the product can become rancid. And as we've heard from Carel earlier, it's the ability to actually adhere to the program for long enough which matters. If it doesn't taste good, that's a problem. Suggestions that protein content should be increased. We have no problem with the amount of weight loss being achieved using current recommendations, which are all extremely good, as I've described to you. The problem with protein is, again, that it doesn't taste so good. It adds the cost to the program, and it can make the diets unpalatable. And there seems to be no reason to increase the protein content. Finally, there's a recommendation to include choline, which is a bizarre one because choline is not a required nutrient for adult humans. So we can come back to that in discussion if you like. My conclusions are that type 2 diabetes results from excess body fat and age in those who are predisposed to export it into vital organs, but it is reversible. And we should now make remission the primary aim of diabetes care, recognizing that not everybody can achieve it first time round. We will need additional medications. And I think we should be then making it an ethical issue that we do not offer any kind of drug or other intervention for type 2 diabetes or for obesity without offering the very best diet that we can. And I think we've gone some way towards showing what that is. And finally, I just would like to say thank you. And the next slide should be, I don't need to go into this slide. Next one, please. I don't need to go into that at this juncture. This again is relating to the recommendations. There's an expression in English, if it ain't broke, don't replace it. Can we move on to just the thank you slide? Last slide, please. That's it. Gone back. There we are. Simply want to say thank you to my team, who have been working extremely hard, way beyond the call of duty or requirement or even what they're paid. And to thank particularly the donors. This work was entirely done on charitable donations to Diabetes UK, a charity which speaks for people with diabetes and puts them in contact with the professionals who want to help them. Thank you very much indeed.
Thank you very much. That has generated a number of questions which are interesting. One of them is from Faten Bayado, who says, do you think the speed of losing the 15% of excess weight to achieve remission matters, whether it's lost over a month or over 3 to 4 months?
Yes, I'm not going to give a simple answer to that. If you ask the patients what they want, they will say they'd like to get this done quickly, they'd like the rapid weight loss. And when we have compared patients, we've offered them a more rapid approach using total diet replacement with a food-based approach, they almost all elect to go down the total diet replacement. There are some who say, no, I prefer to do this very, very slowly. Most patients find it difficult to go out, keep this going for longer, and so getting on with it gets a better result. And we are now seeing repeatedly in all the studies that more rapid weight loss brings better long-term results.
Thank you. There's also a question about age. What was the age of participants in the direct trial?
The average age was 54, which is typical. It's about the average age of onset, being about 51 in Scotland. So 54 is the average for people who had diabetes for about 3 years. There's no reason why this wouldn't work in substantially older people. We focused on the younger ones because that's where the greatest burden of pathology is. But I don't think there's any particular age band that we would focus on. In the results at the end, it did appear that patients who are older tended to do slightly better with weight loss, and not to a major degree, but they did slightly better. So it was actually quite rewarding to work with older patients.
And the second part of that question was, in fact, can this be provided to anyone over 75? And this also relates to an earlier question that came up from Manuel Alves, which is, what is your opinion on sarcopenic obesity? Do we need to measure muscle mass in some of these people?
Yes, the answer to the over 75s is you have to weigh up the effort, and it is quite hard work to do this. There are many 75-year-olds or older who are willing to put in that effort and who benefit from improved mobility, who feel better after they lost weight, and their metabolic state does improve. Whether that would translate into improved quality of life expectancy, I think, is more difficult once you're into 70 or 80s, especially. I think the medical gain is likely to be a bit less. You also raised the question of sarcopenic obesity. We know that a number or a majority, perhaps, of the older people in their 70s and 80s with obesity actually have very low muscle mass. There has been concern expressed that perhaps if they lose weight, they will lose muscle mass. That only happens if they're inactive. And what we find is that people who are able to lose weight are able to maintain their physical activity rather better. And I think it's important to recognize that during any weight management trial, we do also always recommend that patients maintain physical activity as long as they can, and then begin to increase it after they've lost weight. And that should protect the muscle, in fact, even increase muscle mass in the older patients. And that's been seen, that was actually seen in the Look Ahead trial, where they found that there was, in fact, a gain in muscle mass in patients who did quite modest physical activity to promote that.
Okay, there's a question about magnesium, which we'll take in the general discussion, but from Elizabeth Beltran-Lopez, are these shakes high in protein, low in carbohydrates, and so on? What are your thoughts on the low carbohydrate diets?
I had a slide on low carbohydrate diets. There have been multiple meta-analyses on low carbohydrate diets, and we've just completed another one with one of my colleagues, which all show there is no difference in outcomes whether you use low carbohydrate or high carbohydrate. There is no difference. Now that's in randomized trials where you randomly allocate one diet or the other to people, and there is simply no difference in terms of weight loss, in terms of diabetes control, in terms of blood pressure or lipids. There is no difference. But I think it is important to recognize that there are some people who prefer high carbohydrate type of approach, and there's some or low fat approach, and there's some people who prefer a low carbohydrate approach. We can accommodate them both, and I think it's important that we recognize that.
Okay, thank you very much indeed.